right, so I'd just like to introduce Dr. Pooja Agrawal, who we're fortunate to have today to give us key information on how to recruit women and retain women in emergency medicine. And of note, Dr. Agrawal is also the president of the Academy for Women in Academic Emergency Medicine. Thank you so much for being here.
Okay. Can everyone see me? Yes. So I apologize. The program says I was going to be speaking about refugee health, which is my other area, kind of my area of research focus. But Dowin asked me to speak about kind of recruitment of women, as for some reason we're still kind of considered within diversity initiatives. Women are part of that push, and so I'm actually going to be speaking about the recruitment and retention of women. And I know the focus is on clerkships and getting women into the field, but if you think about it, you have to get them into the field and you have to keep them in the field, and actually we have a problem in both. And so if you think about kind of when I'm with this talk, kind of consider the entire spectrum of a career, from bringing women into emergency medicine to keeping them and empowering them and making sure they're successful. So that's kind of where the background of my talk is. And there is more. Should I use this instead? The arrow, it's not doing much. There we go. Okay, press harder. So just a brief kind of overview. I'm going to talk about some of the numbers. I want to kind of show you the data. Some of you probably have seen these data. Talk a little bit about what disparities actually do exist for women in emergency medicine with, again, some kind of hard numbers to back it up. Why does it matter? Why should we even care about this? And then we'll talk about strategies for recruitment and retention. And if anyone in the audience has anything they want to add, please, I'd love to make this more kind of conversational and interactive. So historically, back in 1970, there were 7.6% of people in medicine, in the entire field of medicine, was women, 1970s. That's it, right? The rest of it, men. Over the next 25 years, because of Title IX, because of different kind of diversity initiatives, we've gotten to 50% of women in medicine, in all of medicine by 1995. And that number has been pretty much stable. So in all of medicine, half women, half men. How does it look for emergency medicine? So this is from I know it's really hard to see, and I don't expect you to read all the things on the side. Basically, look for what I've tried to highlight here. So this is, in 2015, if you look at, on the side are all of the different specialties from OBGYN at the top to interventional cardiology at the bottom. What percentage of residents are women versus men? So if you look at the green line, that's all specialties. We are below that, right? So for all specialties, we're kind of about 45% women. In emergency medicine, only 38% of trainees are women. That's below our average. And then if you look at it even further, if you pare it down even more, forget just trainees. In emergency medicine as a field, only 27% of emergency physicians are women. So we're kind of whittling down from 50% to 38 to 27. And then if you look at even further, women in leadership roles, it's even smaller. So only 16% of all chairs of emergency medicine. Actually, I think that actually includes chairs and vice chairs of emergency medicine are women. So that's where are all the women going, and why are they not coming to emergency medicine? What should we do about this, and how can we make this a more kind of inviting and appropriate place for women to be? Where is the disconnect? How do we identify the disconnect? How do we start bringing that number back to where we think it should be? So I'm sure many of you have seen this study. There are several people in the room who are on this board, Bernie and Dowin, and people who've worked on this. This is a great paper from a couple of years ago, basically looking at the numbers. What are the numbers? What is the actual disparity of women in academic emergency medicine? And so I'm going to go through, this is also, they spoke about kind of race and ethnic breakdown. I'm not going to talk about that. I'm just going to focus on the women specifically. So there's a couple ways to look at it. The first way to look at it is, let's look at academic rank. Let's look at, if you take all comers and you kind of look at all the different things, you account for all of the different aspects of experience and kind of ethnic background and fellowship, all of that stuff. You look at academic rank. In the lower aspects of academic rank, so in instructor and assistant level, women are 74%, men are about 59% at the assistant level, right? As you get into the higher levels of the academic rank, so associates and full professors, that number switches, right? That blue line drops and the red line goes up. You have many more proportionate men to women, and this is how it stays, right? And so you can think about many reasons for why that is, but everything else being equal, this is a disparity in terms of academic rank. And then, of course, the 15% of chairs and vice chairs only are women. The other big component of this study that I thought that was very interesting is the numbers, right? So when you break it down, women tend to be more fellowship trained. We'll talk about that in just a second, what the implications of that is. They're less often core faculty, 59 to 64%. They have fewer administrative roles within a department. What does that mean? That means they're less visible, right? They're less kind of in the front, in the face of CMOs and hospital leadership and other departments, the dean, because they're just not, they don't have those administrative roles. So personally, it's hard to really kind of further yourself, even though they have similar clinical hours. So they're working the same, they're not getting the same visibility, they don't have the same kind of benefits of being core faculty. And then the fellowship training component of it, so that you can think, well, how is that even relevant? And I think it goes back to when you consider how women and men consider themselves and how they kind of promote themselves, you often hear that women say, well, I need to be really sure about what I know. I need to be the best trained, the most, the best at seeing patients. I need to know everything I need to know before I'm ready for the next step. I need to get a fellowship trained. I need to get another degree. I need to really kind of work hard and make sure I know my material. And that may not be the same for men. And so women are they're more trained, yet they are less visible, they're less core faculty, and they still work the same. And the most kind of compelling argument is the one at the bottom, right? So if you adjust for everything, so race, religion, rank, years of experience, clinical hours, core faculty status, administrative roles, board certification, fellowship training, all of those things, women are still making almost $20,000 less in academic emergency medicine. I don't think that's defensible, personally, but something we can certainly work on, something to work on. So this is compelling. This is a disconnect here, and this may be part of the reason we're seeing that number from 50% of women in medicine go all the way down to only 16% of women as chairs, right? This is likely a big part of it. So we have a couple of big problems. One, there's a pipeline problem. So women are not choosing emergency medicine as a specialty. And the second problem is that there is a disparity, and that disparity is prevalent kind of across the board in academic emergency medicine. There's a gender gap in salary, in rank, and in leadership positions. That's kind of the whole gamut. That's it, right? When you look at kind of the metric for what you're doing and how you're spending your time at work, those are really the main components there. So a couple of really interesting studies came out in the last couple of years. Has anyone seen these studies? These I find fascinating. So this was from just a couple of years ago. This is not specific to emergency medicine. This is kind of medicine in general. And basically, these are researchers. They're not emergency physicians, but they are researchers, MD, PhDs, who were looking at hospital mortality and readmission for Medicare patients. They just had a big Medicare data set, and they wanted to see if there was a male physician versus a female physician, is there a difference in patient outcomes? And they found that indeed there is. If the male physicians in this study had the same outcomes as female physicians, there would be 32,000 fewer deaths. Right, to let that sink in for a second. So if everyone was taken care of by a female physician, 32,000 more people would be alive today. That's the number of motor vehicle accidents there are in a year, right? That's a huge number. So what does that mean? We'll talk about what that means, and maybe I can hear some thoughts on what you guys think that means. And here's another one that came out last year, which I also find this is specific to emergency medicine. So this came out just last year, and basically looking at how people who come in with a heart attack to emergency department. And what they found is that women patients are 2 to 3 times more likely to survive a heart attack if their treating emergency provider is female. Right? So if you're a woman, you have a heart attack, you go to the emergency department. If your doctor is female, you're 2 to 3 times more likely to survive that heart attack. If your doctor is male, you may not. Which is fascinating, right? Why would that be? What they also found, which is very compelling, is that in the practice groups where there are more female physicians in that practice group, that difference goes away. Not completely, but it diminishes. So if you're a female who comes in with a heart attack, and you're seen by a male provider, but your male provider has many more female providers in that group, then you actually have a better chance of survival. So there's something there that women are doing, women physicians are doing, that are helping patient outcomes and are helping their male colleagues. So women doctors are good for emergency medicine. We bring new ideas, right? So there are not as many of us, but we have new ideas, we have skills, we have interests, we have creativity, we look at things differently. We have an ability to relate to patients that is different than men. And we have a very different way of decision-making and leadership styles. So women physicians in general, they tend to share more information. They tend to ask about feelings and opinions. There's a lot more focus on shared decision-making. While with male physicians, they tend to deliver facts. They give a differential list. They say, this is what I think it is. They emphasize the H and P, and they're much more kind of prescriptive. Which works for many people, but often if you are a female patient, that may not be the best way that you communicate. That may not be a way that you can communicate best with your own doctor. Women doctors are good for men doctors, right? So patients have better outcomes, as we saw from both of those studies that I just showed you. They will demonstrate just by example how they engage with patients, and male physicians will take away from that. Women tend to promote work-life balance within a department, which certainly benefits the women that promote that, but the men also get the benefit of that, of those conversations, of those changes within policy. They push for family-centered policies around time off, around parental leave, around significant life events that men can also benefit from. And the reverse is true. Emergency medicine can be good for women, right? And this is what I think we need to be really kind of conveying to potential trainees, how we as a specialty we can be kind of a good home for women who are thinking about emergency medicine. Besides the obvious, right? Besides the reason we all went into emergency medicine, we like the patient population, we like the pace and all of those things, but there is the potential for flexible scheduling, right? It's there. We may not always use it. We may not always have it in our places of work, but it certainly is an option. We should be thinking about using it more. Work-life balance is a buzzword, and sometimes it seems like it is just a buzzword, but it is something that we can strive towards. And task switching, some people are very good at it, but we in emergency medicine tend to really kind of work towards being able to do that well, and that's something that women can do. We do that all the time in our lives. So we're kind of getting into this whole concept, if you take a step back, of implicit bias. And this is not something that's unique to emergency medicine. It's not unique to medicine, right? Every field, there is some challenges with implicit bias. And Harvard Business Review, I think they write very long articles, but they're all they find them to be very interesting. They've done many articles on implicit bias, and to think about, well, what is it about what's under the surface that we're not either seeing or we're not consciously addressing that's causing some of these disparities, some of these disconnects within how women and men are looking at emergency medicine. So what is holding us back as women? So now just to talk about some strategies, how are we going to solve some of these issues? And if you guys have other ideas, I'd love to hear them. How are we going to solve the pipeline problem? So if you're looking at potential trainees, you're looking at medical students, and you're trying to really kind of get them energized and excited about emergency medicine, what are some ways that we can do that? So start early, right? So take a mentee under your wing, take a medical student, take a college student, have them shadow you, show them what your life is like, show them how you're able to balance your work and your life, show them how you interact with your patients, and let them use you as an example. That'll spark an interest, and it'll also potentially create a kind of a mentorship duo dynamic that can be more longer lasting as they move through their training. If you're part of a program, involve women in your recruitment process. So make sure that if your PD and your APDs are all men, make sure you have some women who are also out there who are trying to bring women in, be it the residents, the chief residents, or even just junior faculty who are doing interesting things. Have them come to an event with your recruits. Have them talk to people during interview day, and let kind of women applicants see that there is a pipeline, there's a pathway for being successful and being kind of highlighted within a group. Pair students and trainees with mentors that can help them through that process. I think the next point is, I think, challenging, but it could be a potentially interesting way and an important way to really kind of bring more women into the fold, is make the admissions process gender blind, if that's even something that you can do, right? Because again, there's always a lot of implicit bias within people who are looking at an application, and so if you blind it to gender, then you may actually get you may get from that 38% to closer to the 50% that you're looking for within emergency medicine. And another thing is that, we have a lot of women's groups, and this is just not a plug because of AWEM, but it's just in general, there are, a lot of women in medicine groups that can help. If you don't have a lot of women within your faculty group, these groups can help you do that. They can help you show that there is a network of women in academic or even just emergency medicine, and we all work towards creating a home for women who are looking at emergency medicine. We work towards creating mentorship paths and paths to success and promotion, and we can kind of help expand that network if it doesn't exist within your own shop. How do we promote the development and advancement of women? Now, this may be not so much at the resident recruitment level, but kind of as you move further. But if you're recruiting at a resident level, you have to show that there's some kind of basis for advancement beyond that. Otherwise, no one will stay within the field. So things like supporting travel to conferences and training, right? So if women are not really they're not as visible within a department, within an institution, find ways to make them more visible. Get them the training that they need. Get them out and networking with people outside of your own faculty group. Nominate women for awards. This is very easy, by the way. And there are so many awards that you can offer to people, that you can nominate them for within all the different women's organizations that exist, within your own institution, within your own faculty group. It's really easy to throw in a nomination letter. It's 3 paragraphs with a CV, and you've done a lot, not just to promote that woman, but also just to give them a sense of, you're doing a really good job, and we really want to make sure that people know that beyond just these few people around you. This is an easy thing to do, but I don't think we do it enough. Amplify and highlight the progress and accomplishments of women. So if someone gets an award, tweet it out, right? Put up a flyer, make sure that people know that it happened. If someone has a paper that's come out, get that out there, make sure people are reading it. These are very easy things to do, and with social media, there's very easy ways to get that information out. We should be doing that. I think women in general are not as good at self-promotion, so let's do that for each other. Allow for more administrative time. So, like we talked about before, women have fewer administrative roles within a department. So if you give them that opportunity to have an administrative role, be it within a committee in your medical school, if it's within the department as a program director, APD, or a medical director, that's a way that you can get women to be more visible, not just within your small group, but within larger groups. And there are many women who are very capable of doing that, and we can think about how we can do that more for them. And then, of course, leadership roles within a department. There's a concept of mentorship versus sponsorship. This is kind of a familiar concept to people. Yeah? I'm not seeing a lot of movement, so I will go over this briefly. So mentorship really is, if you take somebody under your wing and you say, okay, well, I think you should do this, and you should do that, and you should do this, and then you're going to get your CV going, and and you can do all of these things, and I suggest you do all of these things, and this is how I think your career will be expanded. That's mentorship, right? That's saying, well, these are techniques that you can do, you can use, these are steps that you can take. Versus sponsorship, which is saying, I think you should do this, but I'm going to help you do this. I'm going to sponsor you to talk at this event. I'm going to sponsor you to write in this writing group. I'm going to sponsor you. I'm going to get your name in there. So you're not having to make those connections, right? So there's a difference between mentoring and sponsoring. And I really think we should be thinking more about sponsoring women, not just women, but in general trainees, sponsoring them and not just mentoring them. There's a difference in how that affects their eventual outcome and how they end up doing down the line. And then another thing that we can do to help women, and this is what we've realized with regards to women and men, is that women tend to take more time off earlier in their careers, right? That's when they tend to have more kids, they tend to have more family pressures, and they tend to take more time off early. But that doesn't necessarily happen later in their career. So if you've kind of blunted their growth, stunted their growth early, then when they're ready, when they've come back and their kids are kind of on autopilot or wherever their kids are, you know, and they're moving on, now they've lost time and you've lost interest in them, and that's really, that's a shame. And I think that's why people get kind of stuck at the assistant and the clinical instructor level. So think about fostering policies that help women early in their career to support them in the way that they need at that time. Right? So think about scheduling that is more kind of amenable to a family structure. Think about less than one full FTE, right? If someone needs a little bit of time off, that should be okay, right? And that's something that many women need. They don't need a lot sometimes, just a couple of shifts off and, you know, the commensurate pay for that, but that should be an option. Another thing that often will happen is, well, you'll have a social event and it'll be at 6 o'clock in the evening. Well, that's a challenging time for many women, right? You don't have childcare options. You want to be home and spend time with your family. So if you have departmental meetings, if you have meetings that are not even just kind of mandated departmental meetings, but even social events, think about scheduling those during times that are much more amenable to the young women faculty who can really, who want to participate, but just cannot if it's at a later time. Significant life events, so this is beyond kind of childbearing, but also for, you know, major events, deaths and time off and things like that. This is not just a women's issue, right? Men also have significant life events, but women tend to kind of lead the charge here. And so if you can create a policy for women to be able to take time off when they need it, the men in your department will also benefit from that. Family leave, flexible scheduling, so we'll get more into this kind of in the next slide, but thinking about if someone needs some time off, it may not be just a shift reduction, it might just be the kind of shifts that they need. So if it's possible to be a little more flexible in your scheduling, and right now, you know, evening shifts are really hard, but I can do more overnights or I can do more days, and perhaps there's someone else in the faculty group who can kind of buffer that a little bit, that might be something to consider. And then the other thing to consider is childcare subsidies, right? So I'm not saying pay for their daycare. I'm saying think about ways that we can make it easier for people to take care of the other parts of their life that'll make them more productive in their clinical time. So emergency or backup child care, dependent care, and this has really, you know, you can give, there's a disproportionate value to this. If I feel like I'm being supported in other aspects of my life, my clinical time is much more productive because I'm happier at work when I know that the rest of my life is squared away. Now, this did not turn out exactly how I wanted it to, but strategies for parents. So fair and appropriate parental leave policies. So make it standardized, make it transparent, right? Make it something that everyone knows that if you're going out on parental leave, this is how much time you're going to get, and this is when you have to come back. If there's more, it's a very kind of prescriptive way to do it. There's no bad feelings at that point if everyone knows how it's going to be. Lactation accommodations. Have you guys seen these pods in airports? Yeah. We don't even have this in our hospital, right? What's that? They're not on brand. Well, we have nothing. We have like literally nothing, right? So we're pumping in bathrooms and things like that. It's too bad. You can have this in an airport, but not in a hospital, which is really a shame. So think about accommodations for this. This is a really important thing to many women to be able to feed their children when they're at work. And so something small, like a small space with a little area that they can go for 20 minutes and do what they need to do, that goes a lot for their wellness. It's a lot for their wellness. They come back to their shifts and they're much more productive because they feel like they've done what they need to do for themselves and for their families. We should not be pumping in bathrooms. That's just not okay. And then thinking about, you know, when pregnant women and women that come back after maternity leave, thinking about what their needs may be, right? So a third trimester pregnant woman might have a hard time doing overnight shifts. So consider maybe during that third trimester not making them do overnight shifts. Maybe they do them early. Maybe they do them when they come back. When they come back, perhaps those higher acuity shifts are more challenging because they do have to leave to go and pump or whatever. And so thinking about flexible scheduling around those kind of very important times in their life. And I'm not saying just give them those shifts off, but consider maybe you can stack them early, you can push them off till later, get those commitments done at other times, but allow for some flexible scheduling, and encourage departments to take the long view, right? So if you have a faculty member, male or female, who is satisfied, like I said, satisfied in other parts of their lives, they're going to be happy in their clinical time. They're going to be more productive. They're going to be more clinically responsible. They're going to see more patients. In general, it's a beneficial thing. So the elephant in the room, we've gone through all the different kind of social aspects of this, but the elephant in the room is what are the promotion and pay, right? So we saw from those studies that promotions are not happening for women as much as they are for men, and pay almost $20,000 less for women. So what can we do about that? That's the bottom line. That's why women leave jobs, right? That's why they leave the workforce, is because they feel like they're not being valued and they're not getting the compensation that's commensurate to their time. So for promotion, there are techniques that you can use to think about how do we promote women at a rate that they should be promoted. One idea is to have some kind of confidential person who can be a point person for women to go to say, I think there's a bias here. I really think we need to address this at a higher level and have someone, kind of a third party, to be able to take it to a chair or a dean or somebody who's going to be able to advocate for you. I also think that creating a recruitment process and promotion process that's blind is important as well. And so, again, you take a look, you blind if the promotion process is kind of not just your department, but beyond that as well, blind it to gender and really kind of look at those applications next to each other and see there may not be as much of a difference, but the gender might actually play a role in why women are not getting promoted in that. And review that process periodically. And the same thing kind of goes for pay. So auditing the gender-based differences in salaries is going to be important. So take a look and see, well, is there a difference at the assistant level, assistant professor level, or the associate level? Is there a difference in salary? Does that have anything to do with gender? Can we understand why, if there is that difference within our own shop? Because we know it is on a national level. Apply rubrics to standardize the pay. So create kind of transparent metrics to say, if you see this many patients, then you get this kind of compensation. If you do this many lectures, like this is exactly the structure. This is what you need. These are metrics you have to hit in order to make this particular level of pay. So, and make that transparent so you know if you're not hitting your metrics. You know if you're getting paid less, why that is. And then elevate that issue. So if you feel like that you're I'm not saying be kind of a disruptor necessarily to the point of affecting your career, but saying, does the dean care about that kind of thing, right? Does the dean care that there's a disparity in pay? Does the dean care that there's a disparity in promotions? And often they should, or if they don't, they feel bad that they don't, and they will. And so that's something that can be elevated outside of your department to really advocate for kind of more equity within pay and promotions. So kind of the bottom line, women should not have to choose between their careers and their families. And often I think that's part of the reason why women are not staying within emergency medicine. But by implementing policies that benefit women, we can recruit women trainees, and we can really kind of elevate this as a group. And that's what any questions or thoughts? Yeah.
Yeah, I'm curious to hear how you feel transgender women or people who identify anywhere on the spectrum of gender fit into these discussions. So I feel like it's so easy to just fall into this dichotomous male-female, man-woman sort of discussion, and I don't want to be exclusive of those folks.
Yeah, absolutely. I think we're just getting data now on women, right? On women who are kind of traditionally, considered and identify as that. And only now we're starting to, those studies were from 2 years ago, which is really kind of amazing since, we've been in medicine for so long. I think personally, data really speaks, and there's just not a lot of data out there. Absolutely, everyone should be included in that conversation, and I think women who are traditionally kind of considered women and consider themselves women, in whatever way if they feel like they're being, if there's a disparity there, then that is going to be even amplified in other populations. And so absolutely we should be part of the conversation. The conversation is just starting, and I think that's something that should be considered even further. Anyone else? Thank you.